On this episode of WarDocs, we have the privilege of speaking with Air Force neurologist Lieutenant Colonel Adam Willis. He currently serves as a Biological Technology Office Program Manager at DARPA. Dr. Willis sheds light on the specialty of neurology and how it supports the operational medicine mission of the armed forces. He also discusses his fellowship training in neuro-critical care and the role he plays on the Combat Casualty Critical Care Team. Adam describes a current project in his portfolio that is aimed at seeing if it is possible to manage a complex polytrauma patient, starting near the point of injury and continuing throughout the evacuation process via a single intravascular cannula that can be placed by a field medic. Find out more about Dr. Willis and our previous guests on our website, wardocspodcast.com. And make sure you follow WarDocs on your preferred podcast platform and subscribe to our WarDocs YouTube channel. I'm your host, Dr. Doug Soderdahl, retired Army urologist.
Welcome to WarDocs, the military medicine podcast. This show brings you a first-hand, behind-the-scenes look into the mission, unique opportunities, and deployed experiences of the entire military healthcare team. From state-of-the-art hospitals in the United States to the most austere environments across the globe, WarDocs has you covered.
Today, we're privileged to welcome Air Force physician Lieutenant Colonel Adam Willis to WarDocs. Adam, thanks for joining us today.
Hey, sir. Thank you so much for the opportunity. Love the program and really excited to be here.
So tell us a little bit about how you started your career in military medicine. How did you first get the inkling that you wanted to be a physician, and how did you get involved with the Air Force?
Originally, it started when I going to college. I knew I wanted. I had great appeal of going into the service. We had some family friends that had done it, and it was just seemed like an exciting way to serve. It was a unique opportunity. So going into college, I was going into ROTC and ROTC, and there I was in actually as a physics major, and again loved physics, very interesting, loved the mathematics, but quickly sort of discovered physics, at least in my school, was a lot of not applied, not real tangible of what exactly you could do to make a device or help people out. And so started to think about, maybe I could combine my love of the math and the sciences with taking care of people. And my father's a physician, and so it had always been in the back of my mind that to consider going to medical school. So I think it was about my junior year. I'm like, why can't I try and do both? Get ready to go to medical school. And after basically sort of midway through, junior year, started to apply to some combined degree programs to do both medicine and do physics or engineering, and was lucky enough to get into a program at Illinois. ROTC Air Force was generous enough to give me time off to do the PhD portion, but there was a little bit of initial hesitancy by the line who controlled me to say, why would you need to go to medical school? How would that actually help to be an engineer and go to medicine? And it was a bit of a journey to figure out how to actually make that case, And as it turned out, I was at a conference in bioengineering about brain-computer interface, and it was pretty cool. There was a guy who was using his mind to move a robotic arm, and I'm like, well, that sounds very cool. Wonder how I can do that. And I Googled who does brain-computer interface, and a name came up on Wikipedia of a Colonel Jeff Ling, who is an MD PhD in the Army. And I'm like, well, that he might know something about how to get this done, how to convince the Air Force to do this. So I cold emailed him, and the first thing he said was to me as I picked it up, he was at DARPA at the time. He's like, "You want to be here." And then we started to talk about, well, how do I get into medicine? Make a compelling case to leadership to get back into medicine, and then and then started to brainstorm. Well, how do I learn to do research, because that's sort of the path to get to DARPA. How do I learn how to do operational medicine? And that's sort of how things set off. So it was sort of a bit circuitous, but it's been an interesting journey. But again, glad I'm here.
So that's a great story. So after medical school, you trained to be a neurologist, and I think you are the first neurologist that has been on WarDocs. So tell us a little bit about the role of a neurologist in the military and what roles do they play in supporting operational medicine?
Typically, neurologists, we worry about disorders of the brain and the nervous system. Within that sort of general neurology practice, you're going to have your strokes. That's a big component, whether they're bleeding strokes or just ischemic strokes. You're going to have things like muscle weakness, neurodegenerative diseases, etc. But there's also traumatic brain injury and seizures. Now, those last two are actually very, very pertinent for operational medicine, because anytime you're dealing with severe traumatic brain injury, these are the things you worry about. So instantly, a neurologist brings to the table understanding of how the brain works under pathology, as well as how to manage and detect seizures, which is absolutely critical in severe TBI. But also, a neurologist can play a bit of a role in the non-severe setting as well, is because traumatic brain injury is a high incidence injury. And the outcomes of traumatic brain injury often are headaches and sleep disruption, and disruptions in, say, cognitive performance. And so neurology actually can play a role there in treating headaches. We're actually very good at doing that. And also improving cognitive performance. This is a new field that neurologists are starting to get into, of not only improving cognitive performance after there's been a decrement, but also how do you optimize someone who's healthy to behave and perform as best as possible. There's some neurologists going in there. And the same could be said for sleep medicine, as focusing in on optimizing sleep to improve performance or, say, reduce decrements from, say, a TBI. So there's actually a lot of ways a neurologist can contribute, but in the sort of the pointy edge of the spear, it's the TBI, but on the other side, in terms of maintaining force effectiveness, there's a lot of roles that we can play over.
Yeah, see, I've always been intrigued with neurology, and I'm a urologist, so I often get confused when I say I'm a urologist. Like, hey, so you work with the brain? I always thought that neurologists, were unbelievably adept at figuring out exactly where in the brain or the spinal cord, the lesion was, and then, unfortunately, didn't have a whole lot of stuff that they could do once they figured it out. You went on and completed a neuro-critical care fellowship at UT Southwestern. Tell us a little bit about that, how that enhances your neurology background, and maybe tell us about an interesting case that you managed recently that gives us an idea what neurocritical care does.
I was fortunate enough that the Air Force, after neurology, allowed me to go to critical care fellowship. And I did that, UT Southwestern in Dallas. And I sort of think about critical care. So within neurology, there's a couple of paths you can take. There's the binary choice of inpatient, outpatient. I didn't have, I guess that was not a style I liked, the outpatient. I liked the inpatient style. And then you can choose between inpatient, hospitalist, stroke doctor, or intensive care physician. I always enjoyed my interactions with the ICU, and I also enjoyed, at least being an intensive care physician, you're actually learning how to take care of the whole patient. And so one of the things I quickly learned when you get to fellowship is, as a neurointensivist, you're taking care of the whole patient who has a severe neurologic injury. So it's a different focus, whereas as a neurologist, you do tend to focus on the brain and the nerves. Here, I have to manage not only the primary problem, but all the sequelae that come out of that. And so a lot of things you see, one of the things we focus on is, at least in neurocritical care, one of the big things is perfusion of the brain after, say, an injury. That's a big issue, certainly in traumatic brain injury, but also strokes, ischemic strokes versus hemorrhagic, et cetera. So that is a lot of the skill set of then taking care of, again, the injury, but also then avoiding any secondary injuries that would maybe make the brain injury worse. And so, again, it's a really fascinating field. And the nice thing is that training sets you up to work in a trauma ICU, which is really sort of the pointy end of the spear for, operational medicine, at least for an intensivist. And that's where I got to practice. After fellowship, I moved to Brooke Army Medical Center and worked in the Level 1 trauma center there. And we had some fascinating, absolutely fascinating patients. And so one, for example, and this is sort of a neurocritical care nerd case, is we had a gentleman. He was relatively young. I want to say 30 something, involved in a motor vehicle accident. He had a displaced femur injury, and he had, I think, a lung contusion. But actually, intracranially didn't have any problems. He was intubated because he had a little bit of hypoxia, and we caught him in the morning after he had been admitted the night before. And I saw him on pre-rounds, and this guy is like giving thumbs up, clearly communicating, doing quite well. Then I go off, we start getting ready for rounds, we come back, and in the between time, ortho had come by to set the basically the fracture, and they gave him some ketamine, I think a little bit of fentanyl. They set it, and then I'm there about 90 minutes later on rounds, and I see the patient, a guy who had previously been breathing spontaneously and very interactive, is comatose. Very comatose. All we basically had was like cranial nerves. And we were well past the time we would be expecting much of that anesthesia to be around. And so instantly, like, why the heck did this guy get comatose? So we, the first thing you always think is maybe there's a bleed we didn't know about. So we quickly got a CT scan, didn't see anything. No acute intracranial pathology that would explain his mental status. Then we're like, well, shoot, let's, we got a CTA to make sure he didn't have some sort of stroke that we didn't see. Nothing there. Then we got an MRI, and the MRI showed linear and petechial changes of diffusion, as well as some susceptibility artifact. And the read on there, on the read was, consider a delayed diffuse axonal injury. And as soon as I saw that, I was like, that doesn't make sense. This delayed diffuse axonal injury doesn't, like, you don't lose an exam later after you got hit. Usually it's sort of a monophasically improving type of event. You don't have this fine, get worse, etc. What it did was it caused me to do a bit of a lit review, because like this doesn't make sense. And if you look at all of the cases, or at least all the ones I could find in the literature of diffuse axonal injury, there's one uniting feature to the clinical to the clinical history. It's long bone fracture. So actually, and I was a little cute in explaining it. Like, the other part of the differential in the radiology was cerebral fat emboli syndrome, which, classic teaching, because in corresponding, he got hypoxic, and we didn't find any other true etiologies. So he had cerebral fat emboli syndrome, as far as we could tell, because it looks very similar to DAI. And I guess the teaching point to this that I tell everybody is actually, in that scenario, although they look horrible, the brain injury can recover. Now, the challenge is, of course, the hypoxia, if you got to get through that. And he did not, unfortunately. But still, it was a very, very interesting case. Total neuro case, but fun, fun in terms of an ICU perspective, unfortunate for the patient.
Yeah, I mean, I think it's great to have a neurointensivist as part of that trauma ICU crew that really can take a very complicating, hey, this guy was thumbs up, an hour ago, and now he's completely comatose, and try and figure that out. One of the other things that you talked about was your interest in operational medicine, and you also trained as a flight surgeon, and you have a special experience identifier as a critical care advanced transport team physician member. So we've talked about CCAT on the show before, but who exactly is on the team? And what does that team offer as far as capabilities for an aeromedical evacuation?
I've had the privilege to get trained, yes, as a CCAT physician, went through the training, have not deployed in that role. But yeah, so the CCAT team is, from the sounds of it, it's like one of the coolest jobs in medicine, where you get to basically run an ICU on the back of an airplane. And that team typically consists of a critical care physician, a critical care nurse, and a respiratory therapist. I was able to go because I was a critical care physician. I've been to C-STARS or was it CCAT Initial once, and then C-STARS, CCAT Advanced twice to maintain the training. And first of all, there's not a better training experience that I've been through in terms of making you a better physician. It's a humbling experience because it's hard and you make silly mistakes that you'll never forget. But it's also, again, best training I could imagine. The role of CCAT is to take sick people and get them to a higher level of care at the most general sense. And I actually think that going through that training and going through sort of thinking about that has really sort of framed a lot of what I do now at DARPA in terms of basically driving some solutions towards that challenge. Because bottom line, CCAT is a high intensity in terms of resources effort to get a single patient out of theater into CONUS to that higher level of care. And at least this is Adam Willis's interpretation is, much of trauma medicine has taught us that you need, in order to maximize survival from traumatic injury, you need to get to the definitive care as soon as possible. That takes a lot of effort, and can it be done at scale? And that's the challenge, I think, and that's a lot of opportunity that I'm using with my time at DARPA to try and see how we can address those problems of either reducing the constraints of accomplishing that evacuation. For example, the golden hour, that's going to be very, very difficult. Can we loosen that constraint? Can we buy more time to accomplish the evacuation? And then, how can we create technologies to do patient movement at scale to allow patients to move to the ones who need it, move to that definitive level of care for survival and minimization of morbidity.
So just another kind of neurology nerd question. Is there any particular things that neurologically you have to be aware of when you're treating a patient at altitude and pressurized environment on a CCAT mission?
Yeah, I mean, they train us, so you always want to watch out for, and this is sort of one of the level checks, like if there's gas or pockets of air that are in the skull, depressed skull fracture, et cetera, you're going to want to limit your cabin altitude. The challenge, I would almost say it's almost not scarier, but as a neurointensivist, one of the things I live and die by is the clinical exam of the patient. Now, one of the goals within CCAT is to keep them patients as comfortable as possible, sedated and often intubated. That's at least how we're trained. And when you do that, you lose your exam. So me as a neurologist, a lot of the things I want to know to make sure that bleed didn't get bigger, the intracranial pressure didn't go up, it's gone, right? You can look for pupil dilatation, but that's a pretty late marker of badness. And seizures are going to be hard to detect. Acute changes in mental status are going to be hard to detect. So it's at least for a neurointensive, it's a little harrowing because I lose my exam and I can't often just wake up the patient, get a good exam, and put him back down, just because there's a lot of constraints in what you can do, and you can't really have a patient wake up, go berserk, because that's actually one of the challenges of a TBI patient. If you wake them up for a neuro exam, they can get out of hand. You can't do that in the back of an aircraft.
I mean, that almost sounds like a project that DARPA would be interested in, and trying to figure out how to do that neuro exam without putting the patient and yourself at risk or the mission at risk. But let's get into that DARPA conversation. So we've mentioned it a couple times, and for those who don't know, DARPA stands for Defense Advanced Research Project Agency. And I became aware that you became a part of that through a Service Chiefs Fellows program on the behalf of the U.S. Air Force. Tell us about how that happened and how that works and how you actually wound up at DARPA.
First of all, I wouldn't be where I'm at through this whole chain of events if other people didn't go out of their way to help me, which is, that's just a theme in life. And specifically for the DARPA Service Chiefs Fellowship Program, it was an NCO that we had in our department who was very good at taking care of everybody in the department. And he saw an opportunity pop up on email that passed by me that said there's a Service Chiefs Fellowship Program. And he brought it to my attention. I'm like, shoot, I would love to try this. I would love to try and get to DARPA, sort of as Jeff Ling had recommended early on, at that point, probably 7 years ago. And so I looked into the application, and the application was required not only support from my local command, but we would also have to make my local leadership, my squadron commander, my department head, but also required the general to sign off on it. And again, the organization, this is the 59th Medical Wing, really jumped through some hoops to put together a good package for me to put this application forward. They put it to General Ryder, and she wrote a letter, and it got submitted. I got so was lucky enough to be selected as an alternate initially, and then I got an email a couple weeks later after the alternate said, "Hey, could we know in the next." I don't know. It was a very short amount of time of like, if you'd really want to do this because the slot opened up. And so I had a quick chat with my wife to say, hey, I might be gone for 3 months. Are you okay with that? And we got to a position where we could do that. And so I said yes, and then got brought on as a service chief's fellow here. I would say this is an accelerative event in my life, because when you come as a service chief's fellow, you're basically given time, 3 months roughly, and you're given freedom. And someone else described it, it's a make your own adventure kind of event. You show up here, and your instructions are learn as much as you can, talk to anybody you want to, and try and become a liaison between the services and DARPA. And so basically, while I was here, I got to see a lot of different things, anything from Space Force considerations to strategic considerations, understanding artificial intelligence. And of course, I spent a fair amount of time in the biotechnologies office and also working in the defense sciences office. One of the roles is I was so lucky to have another program manager here who just pulled me in and said, hey, do you want to learn how to build a program? Because I'm building one now, and I think we could work together. And this was Greg Whitcop here at DSO. And so I basically spent a good chunk of my time just working with him on how to build a program. That was fun. That was really, really exciting. And so I sort of got a taste for it. And by the end of my time, I let everybody know that, hey, I would really like to come back. And the leadership team for the Service Chiefs Fellowship hooked me up and got me interviews with the couple office leads. And I was sort of put on a trajectory where I could apply to become a program manager. And so, again, the common theme of people keeps taking care of me and really helping me out. And so I got helped out to get there. And then once I was here, people helped me to further find opportunities.
So it sounds like a great opportunity to, really get involved and figure out what DARPA kind of does and get your, interest whetted a little bit. And now that you're on the ground managing programs, one of those programs that you're involved in is very interesting to me, and it's called GOLDEVAC. And you guys have the best acronyms, I have to say. And it stands for Golden Hour Extended Evacuation, and it aims to test whether it's possible to manage a complex polytrauma patient, starting at the point of injury, continuing throughout the evacuation process with a single intravascular cannula that could be placed by a field medic. That sounds like, 2080 or, the year 3000 stuff. Where are you with that project currently?
Yeah, no, thank you so much. Yeah, that is my baby. That was my first program that I pitched. And we're just getting through contracting. We've done source selection. We have some recommendations, and contracting's ongoing. So just, it's a fledgling. It's just a hatched program. But so it's just getting going. But it's a really, again, my bias is here, but I think it's a really, really fun program. But it's also an important program. And it goes back to that theme of how do we buy more time to accomplish the evacuation? And one of the hypotheses that we're leaning on, and it is not just mine, but is that if you can provide early, high-level intensive care medicine to a casualty, you're going to be able to extend the amount of time you have to get them to that next level of care. So this is one of those efforts to try and reduce the constraints of the golden hour to still have good outcomes and accomplish the evacuation. And so when we looked at that problem of, how do we provide intensive care medicine in the field, we had a vision whereby in some future that if there's a large number of casualties, you have a medic who's able to pull out a single device out of a backpack, say it fits in an M9 backpack, put a single catheter into a casualty, hook the two up, press go, and this thing's going to be delivering the kind of care I deliver in the ICU just right from the go, either in a semi-open loop fashion whereby you could allow that medic to take care of a lot more casualties that are high level, or in a closed loop fashion whereby you could harness any vehicle of opportunity to accomplish the next step of evacuation to get them to, say, a roll 2. There, it's continuing to give care to increase the hold capacity of a roll 2, either before and after surgery. But then this care could continue to and augment the number, say, critical care patients we could take on the back of a C-130 or even a C-5 to really maximize our ability to move the patients out and continue that evacuation process. So when we looked at that vision, that's the vision, that's the world we want to live in. We started, we could break that care system into 3 key components. One would be, sort of a small form factor sensor that you could put on the patient and assess the state of the patient to sort of know what's going on. The Department of Defense has invested heavily in that, as well as there's a strong market for miniaturized medical sensors. So, like, DARPA actually didn't need to go after that. That's being developed. We can just harness what's already being developed. Secondly would be control systems. How do you have a control system that would adjust give blood when you needed to, give the calcium when you needed to, adjust the gas exchange ratios to make sure you're not getting a hypoxic or a hyperacidotic. That actually has matured too. There's a lot of maturity there. But when we looked at the real DARPA hard challenge would be is how do you get all that care? And by all that care, I mean not only providing the medicines, but also could you get all the gas exchange or a good portion of the gas exchange in through that catheter, so that way you don't even need to worry about either cryoing the patient or intubating the patient to provide lung support. And to get that kind of access to a patient through a relatively small cannula, we're going to say less than 15 French, something a field medic could place with a little bit of extra technology. That's a fluid mechanics problem because you've got to get a lot of flow through a very small tube. And you've got to be smart about it to make sure that flow isn't, say, there's not too much shear, and that'll open up blood cells and lyse blood cells. There's not too much stasis in and around, say, the system, because that's going to lead to clots. And creating basically that you could put this ECMO-like cannula into someone, but without all of the complications of ECMO, vascular injury, thrombotic complications, etc. But also that you can make sure you can do that without anticoagulating the patient, which is typically done in ECMO runs. And so that's the DARPA hard problem, is can we show that it's possible to get that care through that cannula and then just build a notional, we'll call it breadboard system around that to show that, yeah, this system could exist. And if once we show that this system could exist, then we can start to talk about how we would actually make it and then build a product that could be fielded.
So how much stuff do you actually do at DARPA to figure that out? And how much do you deal with industry to say, help us come up with this technology that would create a smart, miniaturized, non-anticoagulated ECMO system that takes care of the patient, maybe through AI decision-making algorithms? Where does DARPA do the work, and how do you get the industry involved?
That's the interesting part, or that's the difference of being at DARPA. Yeah, because you're exactly right. There is a clean line that DARPA, I don't do research. So my job as a program manager is to set up the vision of the world I want to live in. Then I have to take a step back and say, what is the absolute question that we need to solve? What's the capability we need? And then I have to construct sort of a set of rules that would allow us to, first of all, accomplish what we want to accomplish, but not constrain the solution to only things I thought about. And so that's an interesting exercise because I know how I think I would go after this, but I got to make sure I allow solutions that I never thought of to play in that, because that's the power of DARPA, is we basically have to construct the question right, then throw it out there to let the innovation that exists within industry, within academic centers, et cetera, allow them to come up with things that we never thought about to tackle a problem that to some sounds impossible. And so that's actually that's one of the fun parts of being a PM is, yes, craft the problem right so that then you can let the innovation of other people who aren't you try and solve it.
So where does DARPA get its funding from? Is it connected to the DoD, or is it got its own funding stream?
So we are connected through the DoD, and exactly how things flow from there, I actually can't say. I wish I probably should know better than I do.
That's okay. I mean, I spent 30 plus years in the military. I never figured out how all the funding systems worked. It's that one slide that you get that has 5 billion boxes that says how the Army works or how the Air Force works. You're like, okay, I got it now.
Exactly.
Well, so I want to talk about one of the other projects that you're involved in, and it's got another nifty acronym, SNAP. So the Smart Non-Invasive Assays of Physiology, and in this one, you're trying to look for a portable, non-invasive device that can detect, utilize molecular biomarkers to predict warfighters' stress and physical cognitive readiness. Tell me, what is the question that you're asking, and what is the perfect world look like that has this thing?
Yeah, no, thank you so much. Again, this is a great program. Now, I wish I could take credit for it. The concept, I inherited this from Gopal Sarma, who preceded me. And again, I think it's a absolutely brilliant program. But yeah, the vision, or, the world that we wanted to live in, the technology that would get us there, is that you have some operators who are somewhere and you want to assess, say, among the team, how ready is an individual relative to their baseline? Namely, is this person relative to their baseline ready to do a very vigorous, physical operation? Or, and this is perhaps more challenging, is this individual ready to do a 12-hour mission where they've got to really keep sharp and focused, and how ready we are? And this is not really meant to be it's not meant to be a decision of go, no go. It's actually more informative for maybe who leadership would put on a team, gathering a team, but also perhaps even more importantly is it could be a tool to the individuals to let them know how they're ready to go, and or how ready they are, so then they can get themselves right. They can focus on their sleep, focus on their nutrition, etc. So it's really more thought of to be again a tool to support decision making as opposed to an actual decision itself. So that's, I think, an important thing to get out of the way. And so the world we would want to live in would be, you'd have this capability, and this capability could be run by, say, have the form factor of a COVID test, or maybe one of those handheld glucose detectors that people use to check their diabetes with. Really small form factor, where you could spit, provide saliva to it. It would do some analysis on the biomarkers that were within that fluid, run a model, and give you a score of how ready you are. And so that's the overall vision. And I really think the DARPA the exciting part of that is leveraging molecular techniques to detect, say, the biomarkers of interest that would feed into those models to give you that prediction. And so I'm very, very excited where that's going, because our teams are doing some really, really interesting work to really hopefully detect a whole host of biomarkers. But since they're using molecular techniques, you could actually collapse that capability into something that looks like that form factor I described, be it a COVID test or something small, and that would be completely deployable. So we're sort of testing those hypotheses now, whether this is possible, but really, really excited where this is going. We're going to have an end of phase demonstration, hopefully in a year, or a little less than a year, to really sort of test that first hypothesis. Is this possible? Or are we really going in the right direction? And then we'll go from there. So it's very, very exciting program.
So when you're hanging out at the DARPA water cooler and people are talking about stuff, what is a current gap that people are talking about? Say, our next program needs to look into XYZ because that's a big problem that just needs to be solved? What is something that would be in that conversation?
It's interesting. We almost sort of flip it. Like our DARPA, we almost sort of flip it as what the problems are already out there. Like a lot of the problems are already out there. It's almost what are the opportunities to make a big impact and solve a problem. Maybe not even creating new problems, but really focused on, where is our opportunity to push technology to solve a problem that exists. That being said, we within the office we're very focused on what can we do to maximize warfighter survival in future operations, large scale combat operations, et cetera. That's a very very hard very hard problem, and the challenges are identified. Another thing we do focus on in the office is operational biotechnology of how could we use biomolecules, bioinspiration to solve problems in a new way. And again, I'm not the best person to talk about that. I don't have any programs in that area, but there's a lot of our team member that's looking to use biology in a clever way to bring new capabilities that you couldn't get, or you would be much more difficult to get using, say, traditional methods of semiconductors, traditional sensors, et cetera.
So, one of the things that I was, concerned about is that in the battlefield of the future, all of this technology, could be hammered by EMP or something that prevents it from working. Would that be something that DARPA would be looking for, like trying to figure out how to make stuff that doesn't get impacted by efforts to impact it?
And so it's almost on a case by case basis that we sort of look at in individual technology, and we look for really, as opposed to sort of actual solutions, we tend to focus in on how could we develop new technologies that maybe could be potentially used for, say, some of the applications you're bringing up. But we tend to take it a step further of less of application, certainly within our office, but more on what science could we develop to create new capabilities that someone could use, for other things. So we really are almost in the model of testing scientific hypotheses or almost technological hypotheses as, is this possible? And then let the services, say, pick that technology up and drive it to actual applications. So it's a little bit vague, but we actually tend to focus on, again, sort of individual opportunities and really testing sort of technological hypotheses of when we think we could get a changing technology, world-changing technology, if we just had some targeted investment.
And so if you guys in one of your programs or projects, you say, this is possible. We figured out it's possible. We've got folks who were interested in picking this up in industry. Is that something that the services then kind of get together and look at and say, yeah, this is what we want, and then maybe we don't do them? Or do they just do all the programs that are successful that you guys do?
No, this is the part of the job I didn't realize when I got here, but it's probably one of the most important things we do is, as you build a program, it's almost a living creature that you have to mature and guide in its maturation process, because we want our programs to develop into something that a transition partner can pick up. And so we're always looking for guidance, and we're always having discussions with our potential transition partners of asking them, what would you want to see out of this technology so that you could pick it up and drive it to the next level of advanced development? So it's really, we call the term is active program management, namely where you're not just one and done. As you evolve and you push the program while it's alive actively to guide it to land into a particular transition partner. And during the whole time of your tenure at DARPA, you're always talking to your transition partners. You're always teaming up with people who might have requirements, and you have active discussions to figure out, how can I push this program to a particular transition partner or multiple transition partners, and then really defining what do we need to do to make sure we get it to the point that it can get picked up for advanced development? So it's an interesting process that I never knew about till I got here, but it's one of the more important things we do, because otherwise, if you don't have a transition partner, this great technology might not get picked up. And so that's one of our key tasks as a program manager.
So basically, you're trying to get that little birdie out of the nest safely, and someone else can fly it for, you do the initial nurturing, and then boom, someone else takes it from there.
Exactly. Get the birdie out of the nest to a safer nest where it can grow big and strong.
Perfect. So I suspect that folks are going to be listening to this episode and going, man, this DARPA stuff is really, really cool. Neurointensive care sounds cool. Neurology sounds cool. What advice would you give the younger generation interested in a military medicine career?
Again, I love this question, because again, I first of all, I view it, I wouldn't be here if people didn't help me out. And again, I hope to be, a resource and to anybody sort of wanting to go down this path. And I'd say bottom line, first of all, is high level. It's awesome getting here. And so if you haven't thought about it, perhaps you should think about it, because we get to do amazing things. As a military physician, there's really, really cool opportunities. But high-level guidance and almost reassurance, and this is maybe for people either in it or just about to go in there, is the military does not really waste talent. But again, opportunities show up. You don't know what it's going to look like. But if you sort of establish yourself as having a capability and you're able to justify why what you do is important, amazing opportunities come forward. So just have faith that actually this is a very good meritocracy, and trust that, because great things will happen. The other thing that's interesting, I would say, is when you're in military medicine, and this probably goes for the line as well, having a reasonable commitment to the service is actually a good thing. Because actually, whenever opportunities pop up, one of the first things people will always ask you is, how much time do you have left? Basically because, the Air Force is or the military, the DoD is going to commit to you sort of at the level you're committed to them. If you're, quote unquote, a sure thing, you're going to be around a while. Giving you extra training, giving you additional opportunities is something that they're going to weigh in of how long will you be around. And so I would say, don't be afraid of the commitment. Early on in my time, I realized that, hey, I'm going to sort of take a leap of faith here, but I'm pretty sure I'm going to get to do something cool. And it's worked out. The other things I would think, to focus on is, again, we all might have things we want to do. Make sure you can align, and have a good reason for why what you want to do is in the best efforts, or why this would support the mission of whatever organization you're in. And that there's sort of two sides for that. A, coming up with that narrative of why what you want to do supports the mission, but also making sure you ask yourself, is what I'm interested in actually supportive of the mission? So I always, no offense to anybody who studies toe fungus, but if you wanted to become like a world-class toe fungus researcher, you may not get a lot of traction for what you're wanting to do. That being said, if you're interested in something like trauma, like acute care, there's a lot of resonance, because what you do is very easy to explain to leadership of how me progressing here is going to advance military medicine. So always have that story in line of how you can help the mission. And if you can articulate it, then you have great opportunities. The other thing I would say is, within the business, once you get in the military, is, as opportunities pop up, say yes. You don't know which opportunity is going to give you that next sort of accelerative step. For example, for me, when I got into when I was in residency, there was an opportunity, sort of a targeted opportunity, to do research on post-traumatic stress disorder. Now, as a neurologist, I'm not really, that's not my wheelhouse. That's not the patients I take care of. I take care of sort of the neurologic sequelae, not as much the psychiatric. But it was an opportunity to get some research funding to do that and just sort of show that I could do research. And I took it, and that allowed me to eventually pivot. I got the sort of the street credit of learning how to do research. And then now I can pivot a little bit to say, okay, now I'm going to do neuro research. Now I'm going to do traumatic brain injury research. And you wouldn't have thought offhand that opportunity to do a little original PTSD research would have led to neurocritical care. But, it was hard to predict, but here I am. The other thing that I would say, focus, of course, make sure you're good at what you do, but also really focus on your strengths. And if there's something you do want to be doing, just start doing it. Don't wait to start. For example, and this is my example in research. In residency, in internship, there's very little time to do research, admittedly so. But if you want to do research, you should start doing it as soon as possible, because when you finally have time to do research, when you become staff, and there are other people who might want to do research as well once they become staff, who do you think gets to do the research? It's the one who has previous experience. So yeah, it's not pleasant doing that, but trying to double dip, trying to do research, say residency and training, but it sets you apart for what you really want to do. So really, focus on your strengths and keep getting better at your strengths, so that when there's opportunities that pop up, you're going to be the most competitive to do that opportunity. So I would say, work on that. And then lastly, I would say, be open to an adventure. You don't know exactly how this is going to go. But again, I'm an N of one, but I know other people who feel similarly, is jump in with both feet, see what you can't do to support the mission, and really cool things are going to happen. But again, I don't have too many examples of where that didn't work out.
Yeah, and I think, from your example, another thing is don't sit in your bunker waiting for an opportunity to come to you. Go out and look for those opportunities. Don't be afraid to cold email somebody. Don't be afraid to talk to somebody at a meeting and say, you know what, I'm really interested in X. Is there anything that you can do to get me connected with X? And this is how I think X impacts the mission of our unit. And so I think all of those things that you said are just spot on. So I know this question is often tough, especially for folks who are early in their career. But when the history books are written 50, 100 years from now, how would you want if you could control your legacy in military medicine, how would you like it recorded in the history books?
Wow. So, first of all, this is sort of an easy line of you always, as a program manager, you always hope your program changes the world. So, yada, yada. I hope Gold-Evac really changes the way we do acute care medicine. But I think probably from a more personal side is, I think, again, a strong belief is, I wouldn't be here today if it wasn't for people supporting me and giving me the opportunities. And I really hope, that I'm going to be able to, during my time here and beyond, really help develop opportunities and even a cadre of people where we can do innovation in military medicine. I think that's what I hope to is, can we create a framework by which, military medicine could be like a Silicon Valley for medicine, right? Where we're coming up with great new things for solutions or for problems that only we have. And I think we can do it. And I really hope to be part of that larger, there's a larger effort to do that, but I hope I can be part of that.
We've been speaking with Lieutenant Colonel Adam Willis on WarDocs podcast. Adam, thanks again for sharing your experiences and insights with us. And thank you for your service to the nation. This has been a fascinating conversation. I can't wait to get this published.
Hey, thank you so much. I really appreciate the opportunity.
Thank you for listening to WarDocs. We sure hope you enjoyed it. WarDocs is a nonprofit organization supported by donations from listeners like you. Please follow and subscribe to our show on whatever platform you consume your podcasts, and rate and review this episode, and share the show with your contacts on social media. Find out more information about our show, our guests, and how to become a member of Team WarDocs on wardocspodcast.com. Thank you for your support. If you like war stories and medical drama, WarDocs has you covered. Spread the word.